Hi, let's talk about cardiac conduction and control. In this video, we'll discuss the fibroskeleton of the heart. We'll also discuss cardiac conduction, how action potentials move through the myocardium, the intrinsic rates of various nodes, and what modifies these rates extrinsically. We'll also discuss normal sinus rhythm versus arrhythmias and distinguish between bradycardia and tachycardia. We'll finally discuss extrinsic control of heart function and the cardiac cycle. So the fibroskeleton of the heart consists of the heart valves and all the interleaving connective tissues between the atria superiorly and the ventricles inferiorly. This fibrous skeleton serves as an anchor point, not just for the valves themselves, but for the myocardia of the atrial and ventricular walls, such that the heart can function as one distinct unit. This fibrous skeleton prevents the overstretching of walls, and it serves to insulate electrical signals between the atria and the ventricles, such that exquisite coordination can be possible. And when we speak of electrical insulation, we're not talking about electrons on the surface of a structure. We're talking about the movement of ions along the surfaces of cardiomyocytes. So the illustration here represents a schematic of the cardiac conduction system. And many students, when they look at this, they think of it as a series of nerves within the heart that serve to innervate various parts of the heart wall. What the cardiac conduction system really is an interconnected web of cardiac myocytes. Cardiac muscle tissues are autorhythmic, and they have different capacities for autorhythmicity. Now, there are distinct collections of cardiac myocytes that have various intrinsic rates of depolarization, typically expressed as beats per minute. So for instance, if we were to start here at the subserosal portion of the crista terminalis, we would be in a location known as the sinoatrial or SA node. The SA node is known as the pacemaker region of the heart. It actually has one of the highest rates of intrinsic depolarization at about 100 beats per minute. Now, typical resting heart rate for an adult is between 60 to 100 beats per minute. So the largest range of typical heart rate for an adult is below the intrinsic rate of the SA node. This will be an important fact to discuss later when we talk about extrinsic control of heart rate. As the SA node depolarizes, these action potentials are shared throughout the walls of the atria because the heart wall is a functional syncytium of connected cells. Now, as the depolarization reaches the inferior margin of the interatrial septum, adjacent to the opening of the coronary sinus, it comes upon the atrioventricular, or AV node. The AV node has a lower intrinsic rate of depolarization than the SA node, somewhere between 40 to 60 beats per minute. And it can be influenced by the SA node. So as the SA node depolarizes, so will the AV node. Going inferiorly through the heart septum, moving from the interatrial septum to the interventricular septum, we come across another collection of cardiomyocytes called the AV bundle, oftentimes called the bundle of His. This collection has an intrinsic rate of depolarization of 20 to 35 beats per minute and is nestled in the superior portion of the interventricular septum. Now from here, cardiomyocytes divide into bundle branches, right and left. These bundle branches are distributed throughout the interventricular septum and throughout the walls of the ventricles. On the right side, there's a shortcut of the right bundle branch through the septomarginal trabecula, or the moderator band. And from these bundle branches, both left and right, specialized fibers called Purkinje fibers arise. Now, if there is an issue of conduction anywhere along this point, this can lead to a condition known as cardiac arrest, or the cease of cardiac activity due to an interruption of the conductive system. Issues of conduction can also lead to uncontrollable and uncoordinated quivering or fibrillations of either the atria or the ventricles, as we'll see. So if the intrinsic rate of the pacemaker region is 100 beats per minute, and resting heart rate is 60 to 100 beats per minute, that must mean that extrinsic control of the heart is typically to depress the SA node. Now, there is a cardiac autonomic plexus that we divide into the superficial and deep cardiac plexuses. These plexuses have the same inputs, both sympathetic and parasympathetic, and each of the parasympathetics and the sympathetics have their own visceral afferents. So on the parasympathetic side, high along its course, the vagus nerve is going to send out cardiac branches. The vagus nerve is going to supply a myriad of other thoracic and abdominal viscera with fibers. But these cardiac branches specifically are going to participate in the cardiac plexus. The overall effect of their innervation will be to decrease heart rate and to constrict the coronary arteries. Now, the visceral afferent fibers, so the autonomic sensory fibers that are bundled within these vagus fibers, report back to the central nervous system information about heart rate and information needed for various cardiac reflexes. Now, the cardiac plexuses are mixed, so if the parasympathetic components are coming from the vagus nerve, the sympathetic components are coming from the sympathetic trunks. Keep in mind there are both left and right sympathetic trunks, although only the left side is being shown here, just as though there are left and right vagus nerves. Everything is being illustrated on the left. So sympathetics have typically short preganglionic fibers and long postganglionic fibers, which is the opposite of the parasympathetics that have long preganglionic and short postganglionic fibers. Typically the preganglionic fibers synapse within the wall of the target organ. So when we look at the sympathetic chain, it's good to understand that there are white and gray rami communicantes. White rami communicantes feed information from the central nervous system to the sympathetic trunk, and then gray will feed postganglionics, effectors, back to be distributed throughout blood vessels. Now, there are exceptions to this, and certain branches can leave from the sympathetic chains directly. In the case of the cardiac nerves that supply the sympathetics to the cardiac plexus, we need to consider both the preganglionics and the postganglionics. Now the preganglionics are going to come from thoracic spine levels T1 through T4, and sometimes will also include T5. So those preganglionics are coming from T1 to sometimes through T5, and they can either directly leave the chain from either T1 through T4 to serve the heart, or ascend up to the inferior cervical ganglion, or the stellate ganglion if that combines with T1, which it frequently does. So the output from the sympathetic chain is going to be from the inferior cervical ganglion, or stellate ganglion, T1 if it's not participating in the stellate ganglion, T2, T3, and T4. So inferior cervical through T4 sends the postganglionic fibers out to the cardiac plexus. And collections of these fibers are known as cardiac accelerator nerves, or just cardiac nerves. Now, as the vagus fibers had their own visceral afferent fibers reporting on rate and cardiac reflexes, the sympathetic fibers have their own visceral afferent fibers that carry pain signals back. It's very common above the pelvic pain line for visceral afferent fibers that carry pain signals to accompany sympathetic fibers. And in the case of the cardiac plexuses, this is no different. So let's take a look at the gross anatomy of these cardiac plexuses. So there's both a superficial and a deep plexus. The superficial cardiac plexus is in association with the aortic arch. Generally, it's found in the concavity of the aortic arch, and it's going to be contiguous with the deep cardiac plexus, which is found at the tracheal bifurcation. It's also important that you understand that the deep cardiac plexus is in close association with the pulmonary plexuses. So the autonomics that are controlling the heart and the coronary arteries are also controlling the lungs. They're working in concert with one another. And that makes sense because all of the metabolic conditions that you're going to want to affect heart rate are also going to affect respiration as well. So whenever someone is encountering a sympathetic response, a fight or flight response, the accompanying signs are an increase in heart rate and a dilation of the coronary arteries. So heart rate increases, coronary arteries dilate. This is kind of an unusual situation because usually a sympathetic response will constrict arteries. You have vasoconstriction, but in terms of coronary arteries, we have vasodilation. In terms of a parasympathetic response, the heart rate slows and the coronary arteries narrow. So that's the rest and digest component. Heart rhythms. So normal sinus rhythm includes two things: a heart rate of between 60 to 100 beats per minute with a typical electrocardiogram. So we can see what would be normal sinus rhythm here. And this isn't really an opportunity to get into the granular details of EKG. There is a science and an art to that. But suffice it to say, if we move below or above that range of heart rate of 60 to 100 beats per minute, we move into the arrhythmias. It's also possible to have, an abnormal EKG that would be categorized as an arrhythmia as well. So just from heart rate, anything below 60 beats per minute is bradycardia, a slow heart rate. Anything above 100 beats per minute is going to be tachycardia, or an elevated heart rate. We also have atrial fibrillations. You hear this as AFib. AFib in and of itself can be a chronic condition that's manageable, but it can exacerbate other conditions to rapidly impact someone's quality of life. Ventricular fibrillation, on the other hand, or VFib, is an emergent situation. With VFib, the body's ability to distribute blood to the lungs and all of the metabolically active tissues of systemic circulation is compromised. So VFib can be deadly and lead to cardiac arrest. Now, the cardiac cycle is fairly straightforward. Now, blood, as it moves through the cardiovascular system, is just a fluid responding to pressure. Fluids move from areas of high pressure to low pressure. And the heart itself is a pump that applies pressure to blood so that it may be distributed through the vasculature. But the heart will work according to pressure as well. So there are a couple of things to understand here with the cardiac cycle. There's 3 distinct components to it. The first is diastole. Now, when I think of diastole, I think of dilation. What happens is the muscular walls of the atria and the ventricles relax. They dilate, and their lumen get larger. You can recall from our discussions of respiration that pressure times volume equals a constant. Therefore, pressure is inversely proportional to volume. So during diastole, the heart is at its greatest volume. As a consequence of that, the inside of the heart is at its lowest pressure. So blood is going to fill the heart. Blood will return to the heart through the caval system and the coronary system of the heart into the right atrium, as well as into the left atrium via the pulmonary veins. That blood flows straight through the atrioventricular valves and into the ventricles during diastole. So at the end of diastole, the ventricles are about 3/4 full of the blood that they're going to push out in a cardiac cycle. Now, following diastole is atrial systole. With systole, we have a contraction. And so during atrial systole, the walls of the atria contract and they squeeze that last remaining quarter of the blood bound for the ventricles out. During this time, those atrioventricular valves need to be wide open. The semilunar valves associated with the ventricles are going to be shut. Atrial systole is followed by ventricular systole. During ventricular systole, the walls of the ventricles contract and blood is squeezed out through the semilunar valves. So the AV valves are shut, the semilunar valves are open, and the walls of the ventricles are contracting to push blood through the aorta and the pulmonary trunk and arteries. Following ventricular systole, we move into diastole. Now, whenever you hear someone referring to just systole, they're referring to ventricular systole. And that leads us to the assessment question in this video, which is fibers that cause a depression of heart rate are conducted by which nervous structures? A. Cardiac nerves. B. Postganglionic sympathetic fibers from the inferior cervical ganglion through to T4, T5. C. Preganglionic sympathetic fibers from T1 to T4 or 5. Or D. The vagus nerves, cranial nerve 10. Well, sympathetics elevate heart rate and dilate coronary arteries. So cardiac nerves are sympathetic. Preganglionic and postganglionic sympathetic fibers are sympathetic. Heart rate is depressed by the parasympathetic component of the autonomic nervous system, which is supplied to the cardiac plexus by the vagus nerves. Cranial nerve 10 is the correct answer. Thank you very much for your time.